Welcome everybody. Today we see the finish line of the educational trip called 4x4, broadcasting from West Indies. As always, broadcasting also with the image of the spectacular Italian pavilion at the Universal Expo, made by the 3 upside-down boats that are a metaphor of the journey that will take us to the indeed Universal Expo to connect experts informing patients on venous lymphatic fake news-free communication. This slide is in honor of the more than 190 pavilions from all the different countries of the world. You see the Spain pavilion and the UK pavilion at the Expo Dubai in representation of the 2 languages we have provided these webinars in. So Spanish on Saturdays from Central America and English on Sundays from West Indies. As always, you can make questions in whatever language in the question and answer box, and they will be answered live or in written form based on the time allowance. As always, we will provide international CME credits certificate, so remember to rely on the organizing secretary for that. As always, in this 4x4 project, we will develop a synergy with the general and internal medicine colleagues for proper advancement in evidence-based venous lymphatic care. This is indeed the main aim of this project, following evidence-based data showing us how whatever kind of specialist we are, whatever kind of health professionals we are, in reality we have more than 50% of chances of having to deal with the patients having to deal with some sort of venous lymphatic disorders. And we also know from the evidence that a lot of work has to be done in this educational road together, considering that less than 50% of the general practitioners have been reporting knowing the guidelines or referring the patients at the right time to the specialist. For this, I'd like to deeply thank all the ones involved in this educational trip, starting indeed from Central America and West Indies, reaching out globally, starting from the 3 companions who have co-worked from the very beginning and actually even before the beginning of the project in preparing the material. So Professor Rial, Professor Bottini, and Professor Zaza Salvatore Lazzarashvili. I'd like to deeply thank Servier for having made possible in an unbiased way this experimental project, I would say, in terms of education, since reaching out for the first time to general and internal medicine colleagues. As always, first of all, I'd like to deeply thank the ones I consider family, huge professionals, and of course, great travel mates. So Professor Bottini and Professor Chi. Oscar?
Welcome, everybody. Hope you enjoyed this educational proposal called 4x4 within the framework of the Continuing Medical Program of the Bwin Foundation and Servier Project.
Thank you so much, Oscar. Now the mic to Willie before we get ready with Willie to fly to the Asian projects.
Good morning, good afternoon, good evening. Thank you for joining us for the multiple 4x4 session. We'll see you in a different venue.
Thank you so much, Willie, for all you've done, and in particular, Oscar, for all the co-working, in particular with the Central America version of these educational webinars. It is very beautiful to be here with Willie, remembering the wonderful time we had at the AVLS and all around the world with a huge pillar in terms of education, Dr. Diane Newhart. We all know her as one of the most expert ultrasound experts indeed we have around the world. So please, Diane, open remarks for you now.
Thank you for that very kind introduction, and welcome everyone. I would say good morning from Arizona, Scottsdale, Arizona, where it's raining quite heavily for the last 4 days. So we've got all our rain now that we need for the year. So this 4x4 session is exciting because, as Sergio had already emphasized and others, I think it's so important that we integrate care among all specialists. In particular, my experience with the American Vein and Lymphatic Society has always been an inclusive society, recognizing the importance of all professionals, physicians, specialists, and I think this session here will just drive that point home. In my experience, I just recently, 4 years ago, merged my practice of independent ultrasound into comprehensive integrated care. So I think that just that name alone really speaks to how we handle our patients. We recognize the importance of having the integration of specialists. So welcome everyone, and thank you for this opportunity to say hello.
Thank you so much, Diana. And now we stay in North America and we move to Canada for the opening remarks of Mandy Wong, another huge figure in the field. You will see that there will be a lot of Canada education involved in today's webinar.
I'd like to extend a warm hello from Canada and thank you for asking me to give some opening remarks for this incredible program. When I started working in phlebology over 20 years ago, I had no idea of the scope of knowledge required to practice skillfully in phlebology. As research continues, the scope continues to expand. If there's one thing that the pandemic has taught me, is that the world is smaller than I used to think it was. Connecting experts from all disciplines from all over the world to enhance each other's knowledge has been a silver lining in a dark period of time. Thank you to the VWIN Foundation and all the societies that have been able to keep us connected. Have a great meeting.
And with this, we deeply thank the two huge experts from the vein lymphatic field. And as always, we develop collaboration and synergy with other fields, and in this case, general internal medicine, in this case, directly from Bahamas with Dr. Miller from the Medical Association of the region. I really like to notice that listen is spelled in the same way of silent, and you will notice that the video is quite silent in terms of volume. And I think this is a difficulty that gives us the opportunity of pointing out the importance of reaching out to the silent regions in terms of education that usually are not heard globally, for which I'd like to deeply thank all the ones involved in reaching out to these regions, in particular from West Indies and Central America.
Good morning. I am Dr. Mukuma Millar, a family medicine specialist and consultant based in Nassau, Bahamas. It is my pleasure to welcome you to the 4x4 Medical Educational Seminar on Evidence-Based Venous Lymphatic Principles. The agenda for this seminar includes chronic venous disease treatment, strategies and techniques, post-procedural outcome assessment, and perspectives from various experts in this field. Venous disease is a significant public health problem. The frequency of venous insufficiency is believed to be increasing within developing nations, most likely because of differences in lifestyles and activity. It is estimated that approximately 1 to 2% of the adult population will present with a lower limb ulceration, from which 70 to 90% of these ulcers are attributed to chronic venous insufficiency. Continuing medical education is crucial to the prosperity of healthcare providers. Physicians can help drive increased patient satisfaction and more positive patient outcomes by participating in continuing medical education. Continuing medical education will help physicians stay up to date with the latest advances in their specialty, as well as filling in any knowledge gaps. This will, in turn, allow us to immediately apply what we learn, including best treatment methods when dealing with our patients. The refined skills and knowledge physicians pick up from diving into CME activities should help us all improve overall patient care. Thank you.
With this synergy between huge vein lymphatic and internal and general medicine figures, we get started with the educational trip with the first 4x4, let's say, car from Jamaica, Dr. Frey, talking about CVD treatment strategy and technique. Here we have his lecture, and then we will have him with us live.
Good morning, everyone. It is nice to be a part of this faculty looking at the different aspects of venous lymphatic disease. My talk will be looking at the strategies and interventions in treating chronic venous disease. It will be divided into 4 parts: the strategical options, the technical options, and we look at some of the results and when not to operate. The strategic options are many and are well known, and this includes stripping, sclerotherapy, radiofrequency, laser, and of course, there are newer techniques that are available. All these techniques leads to great saphenous vein ablation. However, when you look at the results of all of these, you realize that the results are more or less the same as the oldest techniques that was proposed years ago by Albert Cassis of cardiomyopathy And the issue is, you know, if we can improve this technique, it's like giving an army new weapon and asking them to move in the same direction. So these different techniques, in order to move, to improve it, we must look at strategies in using these techniques. The guidelines are very clear because radio frequency ablation and laser gives the best result as it relates to open surgery. Therefore, we have to improve the strategies to see how we can improve the results. If we look at the data presented on this screen, we'll see that radio frequency and endovenous ablation has the best occlusion rate, and the other newer techniques still need some more investigation to make them available. If we look at some of the strategies that are used now to improve the techniques, we look at the Cochrane database study, and what they look at was the hemodynamic flow of the veins in the leg, and they found out that saphenous sparing method reduces the recurrence of varicose vein and produces fewer side effects. And this is well documented in this article that shows that saphenous segmental ablation for chronic venous disease treatment is effective and gives better results. So that is our first strategy in looking at all the techniques that are available. So what are some of the options that are available to us? The options that are available to us are thermal tumescence, non-thermal tumescence, surgery, and sclerotherapy. Now, what are the results that we are seeing from these? If we look at sclerotherapy, we'll see that sclerotherapy improves the patient's quality of life. It's easy, it's an office procedure, but in terms of occlusion rate, it is very poor. So the question is, how can we improve occlusion rate? And this is what we're going to be using in this strategy. Now, it is well known that the thickness of the vessel wall is important in achieving an excellent occlusion rate. And this was investigated in the Maradona study, where a device was used to damage the endothelium of the vein and then introduce a chemical agent. And what they found was that there was synergy in this approach in order to achieve occlusion rates. And the result of this is seen when you compare MoCA with radio frequency. And what we are seeing that is at post-operative pain and faster VCSS improvement after it was done. But at 2 years, what are we seeing? That hyperpigmentation and more anatomical failures. This was also demonstrated comparing MoCA with endovascular laser ablation. And we see that the periprocedural pain was increased, but at 1 year, we are seeing more anatomical failures. So the strategy must look at ways in which to improve the anatomical failure. And the novel technique of using cutting catheter-assisted foam sclerotherapy, known as Flebogriff, in which a catheter is placed, the endothelium is damaged, and the foam is injected, was given good occlusion rate. And what we're seeing is that at 24 months, we're seeing 92% improvement in occlusion rate. Now, other methods that are available are the different types of cyanoacrylate glues, such as VenaSeal, VenaBlock, AricaSeals. The important thing to know about that, good results are seen from these, but it has to be used in expert hands. Expert hands, because it creates an inflammatory response, granuloma formation, and there are morbidity that can be associated with it, but it is comparison in terms of achieving occlusion rate. So what we have to tell our doctors is that it's important that this is used by expert hands in order to achieve the best result, as can be seen there. And the evidence is quite clear. The Journal of Venous Disease, 46 affiliation from 5 different continents, and it brings out the evidence that the newer techniques are giving good results, as can be seen here from this diagram, that it's accepted standard for 2016. Mechanical chemical ablation also is accepted standard, and there are variable recommendations all over the world that is showing improved occlusion rates. And the latest journal, Phlebotomy, Journal of Venous Disease 2020, comparing the known techniques such as radiofrequency ablation and laser, which have grade A evidence, compare that with some of the newer techniques, shows that we are now getting evidence that MOCA and GLOW is getting to close occlusion rate. And the evidence here is moving very rapidly. As you can see, within 5 years, we are having results for MOCA and cyanoacrylate glue. It means that the newer techniques using different strategy is giving us better results. And as you can see, at 5 years, there's no evidence that VenaSeal is a bit superior over known radiofrequency ablation techniques. So the evidence again is quite clear. Now, we must be able to tell our patients when not to operate. When not to operate, bypassing shunts in a DVT, supraventricular superficial vein thrombosis, and age is not a limit. Age is not a limit in treating, because it's been done by expert hands and the results are quite good and they are minimally invasive. There are other treatment options such as graduated compression stopping, veno-occlusive drugs such as MPPFF, which has grade A recommendation, and of course the patient lifestyle. And other aspects of this will be done in other talks. So I encourage people to listen to them and get the data available on these treatment options. Thank you very much.
With this, we deeply thank Dr. Frey, and we fly all the way to Trinidad for the second lecture for Dr. Maragé, post-procedural outcome assessment, and then we'll have him with us live for the discussion.
Hello from Trinidad and Tobago, the most southerly island in the Caribbean. I must thank the VWIN Foundation for this opportunity to present on post-procedural outcome assessment. Why are post-procedural outcomes a bumpy road? It is not just about anatomical success. We must be cognizant of the importance of measuring quality of life and PROs. We must aim for early identification of complications, and we must perform follow-up for detection of recurrence. Traditionally, arterial intervention assessment focus on patency rates, while the success of venous procedures focus on occlusion and ablation rates. On the road to practicing evidence-based medicine in its purest form, the surgeon must include the clinical evaluation, quality of life assessment, and the impact on socioeconomic factors as he employs a myriad of new and ever-evolving weapons against the war on venous disease. This table was taken from Catarinella et al. And summarizes the disease-specific outcome measures used in venous disease. Let us look at some of them in a bit more detail. The latest revision of the KEEP classification was in 2020. KEEP is a descriptive tool rather than an evaluative tool and does not assess severity. It does not allow for easy longitudinal follow-up and tracing subtle changes in patient symptomatology. It should not be used as a measure of outcome after treatment. The Villalta scale is an effective tool to assess endovascular treatment of deep venous pathology, including extrinsic compression, DVT, and its sequelae. The VCSS was developed using the main components of the KEEP classification, but is more evaluative than descriptive. It therefore responds more acutely to change and can be used to measure response to treatment. However, the only patient-related symptom interrogated is pain. Some of the more commonly used quality of life questionnaires will now be discussed. The AVVQ's 13-item address non-physical effects of varicose veins, making it more a severity score than a strict quality of life score. The Civic 20 focuses on 4 categories. The instrument does not assess patients with ulcers and is applicable only to C0 to C4 patients. The VANES Quality of Life SIM questionnaire is a pure PROM. It can be used both for superficial and deep venous disease. There is a relatively new PRM on the scene. The VV-SymQ instrument found its origins from the symptom domain of the VANES Quality of Life symptom tool. 5 symptoms, heaviness, achiness, swelling, throbbing, and itching, referred to as hasty, are assessed. The VV-SymQ instrument followed FDA PRO guidelines, including an appropriate recall period and patient input of their symptoms. From a practical standpoint, remember that the gold standard tests, a venous duplex scan, may not always reveal pathology, even when the patient is complaining of classic venous symptoms at follow-up. Be sure to correlate duplex results with the clinical and anatomic findings of the patient. Let's shift gear and look at the well-recognized post-procedural complications of venous interventions. General complications are summarized on this slide. The treatment of deep venous disease brings with it its own complications, now being minimized by evolving and dedicated venous stents. Remember, we are a team. By and large, most complications, including bruising and skin staining, can be managed by GPs who understand venous disease. Having said that, we believe that all complications should be at least initially assessed and treated by the specialist. We learn most from our complications, so it is critical that the specialist follow up the patients post-procedurally. Venous disease is a price we have paid for walking erect, leading to the gravitational effects on our lower limbs. We do not ambulate with our upper limbs. It is important to stress this to our patients as a cause of varicose vein recurrence. Recurrence of varicose veins with conventional SFL and endovenous techniques ranges from 20 to 80% in most studies. Let's look at this a little more closely. In 2000, the Rivas group subdivided recurrence into anatomic recurrence, which is frequently asymptomatic and defined by duplex ultrasound, and clinical symptomatic recurrence. Rivas was also classified by site, cause, and anatomy. Recurrence with thermal techniques, as demonstrated in the Rivas studies, are due to perforating veins, recanalized GSVs, new accessory GSV reflux, and new SSV reflux. Remember, in patients with atypical presentations, unusual patterns of varicose veins, and atypical outcomes, the original pathology may be in the abdomen or pelvis. Look out for unusual patterns of varicose veins. Here are some such patterns. Remember to ask your patients about pelvic symptoms. Be on the lookout for this, as the source of reflux may be higher up in the abdominal pelvic region and can lead to poor outcomes if treatment is confined to the lower limbs. Let us shift our attention to lymphedema. In the early stages, lymphedema can be clinically indistinguishable from venous disease. Lymphedema is not fully understood, underdiagnosed, misdiagnosed, and in many cases mistreated. Approximately 250 million patients are afflicted with lymphedema worldwide. Be ever vigilant. Both lymphedema and venous insufficiency can coexist, and some have postulated that a vicious cycle develops between lymphatic stasis and venous insufficiency. Suzuki demonstrated improvement in lymphatic function with GSV stripping. It is very important to keep this in mind when counseling patients on the potential outcomes when phlebolymphatic disease exists. With the rapidly evolving management of venous disease, it is important that we as physicians critically analyze novel treatment techniques. Self-audit and outcome assessment is important to ensure that we are doing the best for our patients. It is also critical to manage patient expectations. We must emphasize that venous disease is chronic and progressive, and a venous registry helps keep track of patients for follow-up. Thank you for listening.
And with this, we deeply thank also Dr. Dale. It has
Hello.
been a true pleasure working with him, as it is a true pleasure now to introduce, as always, a top expert from the general internal medicine and a top expert from the venous lymphatic field. We will start with Dr. Ononuju in representation of the general internal medicine, making a question live to Dr. Frey. So Dr. Frey, please get ready.
Good morning, everyone. I am Dr. Seni Ononuju, family physician from Jamaica, and I would like to direct these questions to the presenter. Doctor, I want to find out what are the advantages of new techniques such as acrylate adhesive, Clarivane, and Trivex when compared to the older ones like stripping, sclerotherapy, radiofrequency, and laser ablation of great saphenous vein?
I want to thank you very much for that question. An excellent question that a general practitioner, I'm sure, will want to know. Now, if you notice the first technique that was available years ago, stripping, as the technique of occlusion increases, we are using less minimal invasive. We are using, it becomes an office procedure. You don't no longer need an operating theater suite. You can do it in an office setting. And that is one of the great advantages of these evolving techniques. And also, if you look at the data behind that, the quality of life that the patient experience immediately post-procedure is very good. I mean, it's minimal pain that the patient have. They are moving about right away. And as the strategies have been employed to increase the occlusion rate, the technique is getting better and better. And that's my view on it. We are getting better with the newer techniques in achieving quality of life, which is absolutely important, post-procedural, and occlusion rate after some times. Thank you.
Thank you so much, Dr. Frey. I will allow myself to jump in with a personal comment as well, based on the evidence, though. Indeed, we will have in September activities also dedicated to endovenous techniques. And I think it is important we brainstorm among experts, not just with general practitioner and internal medicine, because in reality, for quality of life, we still have to really find proper data supporting the new techniques compared to the radiofrequency and laser that remains actually, according to the guidelines, the first recommendation. So this is something that we have to disseminate, I think, as a concept for the internal and general medicine colleagues. Radiofrequency and laser are still recommended as first grade indication, but of course, the new devices are very interesting in terms of possible minimization also of the tumescent anesthesia part. And with this, we move forward, and it is my true honor and pleasure to introduce a huge figure in the field of venous lymphatics and not only. It is Professor Ayman Fakhri from Egypt. Ayman, if you want to invite us to the next nice events you will do in Egypt and make a nice comment to Dr. Frey.
Thanks, Sergio. I'm delighted to be with you again. Of course, I love to invite you all to join us in Alexandria for the 8th International Congress of the Egyptian Venous Forum in October from 10th to 12th. It will be great to have you all and join our hospitality. And back to Professor Frey, thank you very much. I enjoyed your lecture. It was great, very impressive and very illustrative. But I have a comment. There are multiple theories and pathophysiological techniques for coronary venous insufficiency and varicose veins. That's why we have a lot of modalities, therapeutic agents for treating varicose veins, depending on abolishing reflux and dealing with the reflux as the ascending or descending theory. But in my opinion, we don't reach the ideal method for abolishing varicose veins. I may suggest the Shiva technique for sparing the great saphenous vein and abolishing the reflux could be the first modality till now. What's your opinion, sir? And really, I want to hear from you.
Good, thanks very much. That's a very deep, thought-provoking question. I love it. In fact, when I review this data, it came to me that basically what we are seeing is an evolving pattern in order to get to a state where we can say this is the best. And to be true, I share your view. I believe the Shiva technique is going to come out in the long run to be probably a very promising. And but as you know, we need more randomized studies and that to address that issue. And in my slide, one of the article that was reviewed, where Professor Jehansi, I think they look at 86 cases where they use segmental treatment. And after 1 year, in fact, the quality of life, the patient quality of life was excellent. And after 1 year, there are only 5 patients with recanalization. But as you can see, you know, that we will need more data. I believe in the future, segmental ablation, using the newer technique, probably like Blue or MOCA, to achieve that is probably going to be better for the patient, better quality of life, and I believe it will probably give one of the best results. But as we know, it's an evolving process, and we are always looking at ways in which we can improve the technique using different strategy in order to get better outcome with minimal invasive intervention and a better quality of life for the patient. Thanks very much. Very, very nice question. I love it.
Thank you so much, Professor Fakhri and Dr. Frey. And now we move to Dr. Maragi, and it will be Professor Bottini introducing the next 2 experts.
Let me introduce Dr. Darronel, general practitioner from Curacao. Dr. Darronel, your question.
Hi, doctor. I'm Darronel James. I'm a general practitioner from the beautiful island of Curacao. I wanted to ask you 2 questions. Which quality of life questionnaire do you typically use or you advised to use, and why? And the second one is from the topic lymphedema. What kind of tools can we use to better diagnose lymphedema as a general practitioner? Thank you.
Dale, the mic is yours.
Thanks for the questions, Dr. James. In our clinic, we used the generic SF12 in the past. While we understand the limitations of using general quality of life questionnaires, we have to be cognizant of the patient population, and if compliance with treatment is challenging, far less for patients filling out long and monotonous forms. We in the Caribbean have a short attention span. That having been said, and thanks to the 4x4 project, we are evaluating a modified form of the HASTY tool, which involves having patients score these symptoms before intervention and weekly thereafter for 3 months. Certainly in an ideal world, I would suggest the use of the VANES Quality of Life Symptom Score, or its offshoot, the VV-SYMQ. With regard to lymphedema, remember the basics are your best tools. A thorough history, including family history and travel history, to exclude filariasis. Be sure to exclude occult gynecologic malignancies. Look at the feet for dorsal swelling, which is absent in lipedema. There are many new tests available for lymphedema, including fluorescence testing. I have found that a duplex scan in a trained technologist is invaluable to exclude concomitant venous disease, and with dermal thickening and reduced echogenicity, confirm lymphedema. Lymph scintigraphy can be used to determine the level of obstruction. I look forward to discussing this more with you in person in Curacao over a beverage.
Well, I will join with pleasure with many other friends, I guess.
It's my pleasure to introduce an excellent professor and our friends, Dr. Lazarashvili from Georgia. Sasa, your time.
Thank you, Oscar. Thank you, Sergio. And thank you, Dr. Maharaj. It's a congratulations. It's very important, very comprehensive presentation. It's one of the important topic, not only in phlebolympology, but in global in medicine. And my question is about the complications. Which tools would you recommend for the evaluation of severity of complications? Because in the vast majority of studies focus on only on the numbers of complications rather than the severity of complications. Thank you.
Dave?
Thanks for that very provocative question, Prof. You're quite correct in stating that the current data predominantly looks at the frequency of complications following venous procedures, and very little is published on the severity of these complications. There are a myriad of tools that can be used to assess complication severity, including clinical evaluation, duplex scanning, and venography, be it CTV, MRV, or conventional venography. Your question reminds us of the importance of always scaling or quantifying the degree of each complication. For example, if there's a hematoma, measure the volume and extent. If there's pain, you can use a visual analog score. For thrombosis, describe if the superficial or deep system is involved and the approximate extent. If there's post-procedural edema, this can be monitored and recorded at intervals with a simple tape measure to follow up on circumferential changes. With a multitude of procedures available and evolving to treat venous disease, it is impossible to devise one severity assessment tool that can include from foam staining of the skin post-sclerotherapy to sudden death following migration of a venous stent. Your question, however, is a perfect stimulus for the V-winners to develop severity scales for venous procedures that we do. Best wishes. Thank you.
Thank you so much.
In addition, Sergio, I want to ask, it's very full and comprehensive answer. And there is some classification tools for the complications in surgery, in endovascular, for endovascular procedures. For example, for CIRSE, 2 years ago, published the guideline for the classification of complications of endovascular procedures. And it's a very, very good tool, in my opinion, because it's fully shows us the severity and the grades of these each different complications.
Thank you so much, Professor Lazzarashvili, and also for all the contribution you have been providing during the whole project. We now start with the third card of the 4x4 project, talking about thromboprophylaxis. As you know, thanks to the collaboration of Professor Bottini, Professor Simkin, and many other friends, including Professor Tah and Professor Bishara and all the Egyptian friends, there is a bridge between Latin America and Africa. So today we are enjoying Professor Hussein talk on thromboprophylaxis from Egypt, indeed.
Good afternoon. Once again, I'm honored and privileged to be part of the faculty of this great educational initiative by the VWIN Foundation 4x4 Educational Program 2021. And on behalf of the African Federation of Angiology and Vascular Surgery and my colleagues in the Executive Board, Professors Sharif Assam and Mohammed Ismail, I wish to thank the VWIN Foundation for such a great opportunity. Let me share my screen. We are going to talk in the coming few minutes about thromboprophylaxis in the chronic venous disease and what we should all know. That's my agenda. Why we should be using thromboprophylaxis, probably more than we think. The risk factors involved, the types of thromboprophylaxis, the current updated guidelines, and my take-home messages. To describe the challenge that you are facing in a very simplistic way, and that has been ongoing for so many decades. When we are confronted with a deep vein thrombosis, we are on our tiptoes because this is a potentially dangerous situation. It has local and systemic effects. Locally, it could result in a post-thrombotic syndrome, actually the whole spectrum of post-thrombotic syndrome, but more importantly, parts of the thrombus may be just detached and they go into the pulmonary circulation, causing pulmonary embolism, and that can be fatal. So to answer the question why thromboprophylaxis, you should understand that there are acute sequelae for the DVT extension and pulmonary embolism, and the chronic sequelae, and these are often overlooked. the post-thrombotic syndrome, the recurrence, and the secondary varicose veins. If I liken this situation to the old Cairo, the old beautiful Cairo, but it was beautiful but so simple in the late 19th century, as compared to the modern Cairo, again beautiful but so sophisticated. Therefore, when we are talking about thromboprophylaxis, we should consider three different aspects within the perspective we are in. Varicose veins, the simple presence of varicose veins is an independent risk factor for developing deep vein thrombosis. The recurrence, which often needs extended prophylaxis, and the presence of high-risk groups in some of our patients which require thromboprophylaxis, just to mention a few, but not all. We are talking about pregnancy, morbid obesity, malignancy with chemotherapy, and that's a very high risk group, unprovoked DVT with thrombophilia, hospitalized patients for acute medical illness or surgical illness, patients in the ICU, the major vascular or non-vascular surgery, the congestive heart failure, end-stage renal disease, and the modern times of the pandemic, the COVID-19, which adds to the burden of the disease. Having said that, let's have a quick look on the real-world data from the Rieti screening trial, in which I have been privileged and honored to be part of it as a national coordinator for the Rieti registry in Egypt. We'll find that if you look over here, that 22% roughly from those patients diagnosed as having COVID-19 are subject to DVT or DVT plus PE. On the other hand, like 8% are subject to bleeding episodes. So there are still unknown areas in that domain, and we're still learning from the pandemic. So we have to really think and think hard when we are considering thromboprophylaxis, and we have to tailor our strategy according to the needs of each patient. The types of thromboprophylaxis that we all should know, that there are mainly pharmacologic prophylaxis, anticoagulation predominantly, mechanical like pneumatic compression devices, and the graduated compression stockings. Last but not least, we have to consider reducing or eliminating the risk factors for the VTE. Anticoagulation could be in the form of low molecular weight heparins, unfractionated heparins, fondaparinux, direct oral anticoagulants, and in some minority of centers still using coumadins. Each of these could be having or giving you an edge in certain situations and in certain patients' backgrounds. So we have to use them judiciously. They might be sometimes complementary, not interchangeable as per the guidelines. If we look at the updated guidelines, you will have at least 1.5 dozens of guidelines in the literature. We often encounter guidelines from the ACCP, the American Heart Association, the American Society of Hematology, the IUA, which is often updated every few years again. And you have the national guidelines, and we are proud to announce that we have just had last week, in a coordination and close association with different societies, the Egyptian Society of Surgery, the Orthopedic Society, and the Gynecology and Obstetric Society, our own national guidelines, which would make a great difference in our practice. The issue is you choose whatever guidelines you have in hand, if you consider them simplistic and applicable, but you have to implement them. So prevention of venous thromboembolism in 2020 and before, let's have a quick look on this important, interesting table, which shows us the odds ratio for developing VTE in the different subgroups of patients with different risk factors. Of course, you'll see that the highest would be cancer and surgery. Pregnancy is a special situation. It has been recommended that anticoagulant prophylaxis should be offered to pregnant women with a greater than 2% risk in the antepartum period. Patients hospitalized for acute medical illness should receive, again, anticoagulation prophylaxis, which can reduce the VTE occurrence by 50 to 70%. And we have to use a scoring system. The Padua predictive score, most widely used, and more recently the IMPROVE which is the International Medical Prevention Registry on venous thromboembolism. Surgery is a very special case for us vascular surgeons. We know that those patients who are admitted for any recent surgery, 20% all new cases are having this recent surgery history. We predominantly use low molecular weight heparins. The American Society of Hematology has addressed those special cases of VTE with cancer and chronic venous insufficiency. The strong recommendations include not using thromboprophylaxis in the ambulatory patients receiving cancer chemotherapy at low risk of VTE, but use low molecular weight heparins for the initial treatment of VTE in patients with cancer. Condition recommendations include using thromboprophylaxis in hospitalized medical patients with cancer, low molecular weights or fondaparinux for the surgical patients with cancer, low molecular weight heparin or direct oral anticoagulants for the long treatment of VTE in patients with cancer. Finally, my take-home messages, ladies and gentlemen, more CVI patients than we think are in need of thromboprophylaxis, that's for sure. We should carefully evaluate our patients and use a proper risk assessment model. We should be familiar with the different types of thromboprophylaxis because not all patients are alike, that's obvious. And we should follow the preferred guidelines that we have in hand, but most importantly, you have just to implement them. Finally, you are all welcome for the Joint Congress of African Federation of Angiovenous Surgery and AfroChap 13, which is planned next October, virtually, unfortunately, in Cairo, but we have a strong tendency in the executive board to arrange it and organize it with physical attendance, hopefully next May and June 2022 in either Alexandria or Aswan, both equally beautiful and breathtaking. Thank you very much for the Bwin Foundation. Thank you all. Stay safe.
And with this, we deeply thank Professor Hussein, and I also personally thank him for the collaborations between the University of Ferrara and Shams University. This is the very last car of the 4x4 educational trip, and we are going to enjoy it from Trinidad with Dr. Adedapo, and then we will have the live discussion.
Welcome to the 4x4 Venous Lymphatic Evidence-Based Practice Forward. My name is Adedapo Oladiran. I'll be talking on the follow-up timeline for chronic venous disease, thrombosis, follow-up, and also lymphedema. Just a brief summary of these conditions. We all know about varicose veins, and most of these patients that have surgery for varicose veins have a recurrence of varicose veins in close to 80% of these patients. Now, when they come with these symptoms, we initially do conservative management, compression stockings, we look at their weight, we're talking about weight loss and things like that. Also, diet is very important for this patient and exercise. However, up to 63% of these patients are not compliant. So what do? Should you keep wearing stockings for life? No. So therefore, that comes the aspect of you have to reassess these patients, we have to do a venous duplex, you have to deal with the associated risk factors, there is the aspect of venotropic drugs, and also we need to perform a definitive procedure. Now, a quick summary about deep vein thrombosis and venous thromboembolism. Now, it happens in 1 in 1,000 people per year, and at least 5 of these patients, 5 in 1,000, are those over 80 years old. We could prevent this in our patients. And I would suggest that we give this to our GPs, and some of us might actually have to put in our offices to just remind us the risk factors to look for in venous thromboembolism. What is post-thrombotic syndrome, which is what will happen in most patients? In a third of them, they have DVT. These are chronic symptoms and skin changes after DVT that we see in these patients. Now, it's also known that in most of these patients that if they get compression therapy, within 24 hours of diagnosis, there is 20% absolute reduction in the residual vein obstruction for these patients and 8% absolute reduction in incidence of post-thrombotic syndrome. Now, we need to look at the risk factors for this patient, the modifiable and non-modifiable one, advanced age. We can change our age, of course. Family history, DVT history, obese patients, the modifiable risk factors, We need to look at it when we're managing these patients. How do we manage post-thrombotic syndrome? There's a mechanical aspect, the use of compressed rosary. There is the intermittent pneumatic compression aspect, there's a pharmacological aspect, and also the role of intravenous ultrasound and stenting in those with stenosed veins as leading to the post-thrombotic syndrome. Now, a brief summary on lymphatics. Veins and lymphatics are strictly interdependent. Now, lymphatics could be primary, in which case it occurs in 1 in 6,000 cases, or it could be secondary, especially in patients that have breast cancer and prostate cancer. What is important in both of those patients, or in most of these patients that have secondary lymphedema, is lymphatic dissection, lymph node dissection. It's also associated with chronic venous disease. And we also know that in 80% of these cases, of these patients, they are actually obese. Now, this is really an hidden pandemic walking around. Now, how do we manage lymphedema? Multidisciplinary approach, weight loss, exercise, lymphatic massage, surgical also important. We need to do regular ultrasounds on these patients. Now, how do we follow up patients with chronic venous disease, patients with lymphedema, and patients with thrombosis that we saw before? There is the aspect of early ultrasound post-surgery, which reduces deaths in this patient because we detect venous thromboembolism early. We detect the cause early of that could have resulted in recurrence of the varicose veins, and we treat them. Now, who do we need to work with? We need to work with our GPs. We need to come together so that we improve compliance in this patient and could prevent recurrence of varicose veins, and as well as prevent the aspect of patients keep coming back to us for the same thing. Now, 85% of the GPs refer less than 50 chronic venous disease per year, and they have it in their office. Why? Because 31% of them are just aware of the chronic venous disease guidelines. 11% of the GPs are aware of clinical venous scoring systems. Only 16% referred C3 disease, 43% referred C4 disease, C5 disease, 37%, and C6 when there is an ulcer, when there is an active wound, they quickly refer the patient. So that means that a lot of these patients are managed when the disease has progressed bad. Now, 41% of these GPs will refer just on request. 27% of them are unaware of other treatment options. Only 45% of GPs are happy to provide post-op care for this patient or in epinos minor post-op. My personal suggestion is this. Let's work with our GPs. Let's work with our primary care physicians so that we need to tell them and also let the patient know. In not more than 1 to 2 years from the procedure, let me know how the legs are doing. Let's stay informed and let's properly manage this patient. Thank you very much.
And with this, we deeply thank Dr. Adedapo, and we start with the live discussion. So I ask Professor Hussein to get ready for the question from the General Internal Medicine representative, Dr. Branker from Barbados.
In Barbados, we have a significant number of patients with chronic venous insufficiency, stroke varicose veins, and some of these patients are completely asymptomatic. We use phlebitropic drugs, compression stockings, and surgery as indicated to treat these patients. If varicose veins present a permanent risk of developing DVT, as highlighted in your slides, are you suggesting that patients with stage 3 disease should have oral anticoagulation therapy as well? And if not, how do we select those who need this treatment?
A very interesting question for you, Professor Hussein. Imad.
Yes, thank you so much for the interesting question. So if we are talking about the combination of DVT and varicose veins at the same time, if I get it right, priority should be directed to management of the DVT, of course, as initial step. Proper anticoagulation, by all means, unless the condition is less than 10 days or 12 days old, we might, if there is no contraindication, we might go for catheter-directed thrombolysis. Then we should be following the patient, and after probably a few weeks, we could deal with the varicose veins themselves, whether we are going to be using tumescent thermal or non-tumescent non-thermal. That's a different story. But such a combination is extremely challenging, and I think we have to set our priorities.
Ahmed, I will focus more also on the part related to the varicose veins per se, related risk. So would you consider these varicose veins for these general internal medicine practitioners something they should worry about in terms of thromboprophylaxis per se? And it is interesting, it was mentioning stage 3, maybe it was a little bit confused also on the CEAP classification as eventually a severity scoring that is not, as we know. So
absolutely, Sergio, you have made a point. Of course, we are not talking about exposing all varicose veins patients to thromboprophylaxis, but if we are following the proper risk assessment model and for the proper patient, that would guide us, on top of which Caprini, which I'm going to be answering for the second question from Dr. Janet Bentley from Canada. But we have to bear this in mind. This discussion, which has been ongoing for the last few minutes, is so enriching and fruitful, exchange of thoughts, but even more importantly, exchange of information, especially from West Indies and Central America, to our brothers and colleagues, general practitioners. The mere presence of varicose veins should alarm us, because underneath there is always that inherent risk for developing DVT or DVT plus PE, and this is a golden opportunity if the patient comes to the general practitioner in the beginning. Like more than 50% of the cases will be under his control and under his proper treatment. If we go beyond that, probably there is a room for referring that patient to the specialist. But as a big family, as you just mentioned, Sergio, in the beginning of the session, every day you have a more than 50% chance of dealing with the patient with venous problem. So all of us should be involved.
I think the important message for the general practitioner is the paper from JAM 2018 showing an increased risk of up to 4 times of having a DVT for these patients. And we have papers also up to 10 times. So this doesn't mean that we have to put everybody under thromboprophylaxis, but I think that particularly in COVID time, general practitioners should be aware that having varicose veins is not just an aesthetic concern. And even if it looks like just aesthetics, 26% of these patients just with spider veins are actually presenting a reflux according to the literature. So one of the main reasons why we are running this project. Thank you so much, Ahmed. Now we fly all the way to Canada. As you see, we are preparing the road for the honorary lecture at the end that we did come from Canada. And now we have another huge figure indeed from Canada, Dr. Bentley, and here is a question for you, Ahmed.
Hello, and I am Dr. Janet Bentley from Canada. And Dr. Hussain, I thank you very much for such a concise overview and for your recommendations for thromboprophylaxis in chronic venous disease. My question relates to your opinion on the use of the Caprini score in ultrasound-guided foam sclerotherapy, reticular and spider vein direct sclerotherapy in patients without DVT or history of DVT, but simply having their veins treated. Do you use the Caprini score for sclerotherapy and hence anticoagulate? At what score on the Caprini scale do you prophylax for direct sclerotherapy? Do you differentiate in your mind with foam versus liquid sclerotherapy? And would you tolerate a higher score in direct sclerotherapy without anticoagulation in less risky treatments like this? What is your dosing and treatment time length recommendation in simple sclerotherapy? Which DOAC do you like to use? All of that stuff. Thank you so much for your time. And
try to answer this in 1 minute now, Ahmed.
Yes, what a formidable challenge I have right now. I don't know if I should really thank Dr. Janet Bentley for the multifaceted questions. I'll try to be quick anymore. Um, um, the problem is that if we consider the literature, the setting that Dr. Bentley has mentioned has not been really mentioned to use in each and every case the Caprini score before undergoing foam sclerotherapy or liquid sclerotherapy for the spider veins. However, having said that, let us assume that hypothetically we are having a minor surgery. That means less than 45 minutes. If we consider foam sclerotherapy or liquid sclerotherapy, we liken it to a minor surgery. In that case, it all depends on if we are going to use the Caprini score. It depends on 4 or 5 factors predominantly. Personally, I start by asking the patient, if, of course, the patient has not given a prior history of DVT, but I always ask my patients who come for sclerotherapy if they have a positive family history for DVT to be taken into account. Then, having done that, if we are talking about a female, about age groups 40 to 60 or more than 60, and the mere presence of varicose veins, so each of these would count for one score, 1 point for the Caprini score. Then we are talking about body mass index, 25 or more. And finally, if we are having a concurrent use of the contraceptive pills or hormonal therapy, all these, if we reach a Caprini score of 4 or more, that would warrant thromboprophylaxis. As far as what I prefer personally for the thromboprophylaxis, a dose of rivaroxaban of 10 milligrams per day would be fine for achieving this goal. In ladies, in the last 4 years, I have a tendency to go for apixaban because of a less tendency for bleeding. The dose is 2.5 milligrams every 12 hours, and that's to go for 1 month. Otherwise, the vast majority who would come just for aesthetic reasons with no prior history of DVT, they would not be probably candidates for thromboprophylaxis.
Thank you so much, Professor Hussein, and all the ones involved in this first part. And now we move with the second section, thanks to Professor Chi, who will introduce the two discussants.
Yeah, our first discussant is Dr. Anderson from Guyana.
So we ask Dr. Dedapo to get ready with the live answer.
Thank you for a very clear and precise presentation, Dr. Oladiran. I trust that I'm pronouncing your name correctly. I'm Dr. John Anderson from Guyana. I work at the Georgetown Public Hospital. That's our primary referral hospital in the country. And, you know, I was really happy to listen to this presentation. It covered a number of topics that are pretty relevant to what we see in our practice. Now, I want to ask one question, and that is, I have a 79-year-old male patient with prostate cancer who developed a DVT, and he now has post-thrombotic syndrome. He's currently on Xarelto for anticoagulation, and he's not overweight, pretty adequate weight for his age, and relatively active geriatric patient. My question is, how else could I optimize his therapy to address his post-thrombotic syndrome, since there is still some residual swelling in the affected lower limb, and despite the fact that he is currently adequately mobile and on appropriate anticoagulation, there is still a tendency of the leg to swell from time to time, and it in fact has a consistently swollen appearance in comparison to the unaffected limb. So I'm kindly asking if you can add any suggestion as to how else I may be able to optimize his care. Thank you very much.
Dedapo, the mic is yours.
Thank you very much for the question. I mean, that's a very interesting question. One is a clinical question, which is very good. This is a 70-something-year-old man that had history of prostate cancer, and he had DVT post-treatment. Now, some things you have to put in cognizance here. First and foremost, did he get radiotherapy? Did he get lymph node dissection? Now, if he got radiotherapy, there could be scarring of the veins in the groin. So aside from he just having DVT secondary to surgery or secondary to treatment, we should look at the groin. Is are the veins in the groin scarred? Now, is an adequate anticoagulation on Xarelto? Another part that we need to put into cognizance here is that, was he adequately put on compression therapy when he was diagnosed with the DVT? Now, those are things that reduce the incidence of post-thrombotic syndrome based on what I discussed on the slide. Now, patients that are put on adequate compression when they were diagnosed with DVT, actually there's a 20% risk of developing post-thrombotic syndrome. So those two things: one, the patient on adequate anticoagulation. Secondly, patient actually placed on compression therapy, either single layer or multi-layer, it is irrespective of which, but the compression is important. Even in training that we realize most patients are not put on that. Secondly, we need to look at the groin. Is an adequate compression? Are the veins scared? In that regard, we need to do like maybe a venogram, and maybe if there is scarring or stenosis of the vein, put in a stent, and that will actually dilate and increase venous return for this patient, and maybe most likely help manage him adequately.
Thank you so much, Adedapo. I think the question is really showing the importance of reaching out to the general internal practitioner. If you notice, you didn't even mention graduated compression stockings at the very beginning. You demonstrated the importance of that. And in terms of stenting, I think it's important to point out how this has to be done only in adequate centers, because we have seen around the world an overuse sometimes. So it's very important to stress out also that aspect, I think. And now we move forward, Willie, with another huge figure.
Well, we have one of the pillars of the 4x4 program, a great friend of the VM Foundation, Professor Lazar Shishvili from Georgia.
Thank you, Willie. Thank you, Dr. Adedapo. It was really very important presentation. As you presented one study from 2013, only 11% of GPs aware of clinical venous scoring systems. And I think, unfortunately, the situation has not changed for the better in the recent years. My question is there a need to develop simplified and globally recognized assessment tool for non-vascular doctors? Thank you.
Thank you for your question. Sure, there is a need because just like I said in the slide, only 11% of this of GPs are aware of the clinical venous scoring system. Now, there is the American Venous Forum, the SIP classification, which we all know, which is simple enough, and especially the C aspect of the classification, the C1, the C2, the C3, the C4, up to they might go up to the C5 of the authors, which I think is recognized worldwide. And with the GPs, I actually would say the best thing we could do with them is trying to work with them in educating them more. Like in training that we actually tend to do webinars and seminars with the GP, encouraging them and actually educating our GPs with regards to the SIP classification as much as possible on a regular basis. The advent of COVID has not helped us. So I think there should be a better collaboration between the specialist and the GP in regards to educating our GPs with regards to the SIP classification, which is worldwide and is actually recognized. And there's also a better classification of it now, a more simpler one by the American Vein Forum that was actually developed in year 2000. So the main point here is this: there is a SIP classification, which is actually well understood by the specialist. So it now boils down to the specialist educating our GPs better and working with the GPs in actually educating them with the SIP classification.
Thank you.
Thank you so much, Professor Lazarashvili and Professor Dedapu. It has been a true pleasure sharing also this knowledge with these last 4 cars that are now all going to, let's say, virtually the garage, because we are concluding now the 4x4, but not before the greetings from Central America to West Indies, because as you know, this project has been developed also to reinforce the expertise sharing between the 2 regions. And we have with us Dr. Irigoyen and Dr. Rodriguez. I know they are here live. I've seen them before, so I don't know if Javier would like to go live from here. If not, Javier, I see you there. Would you like to go live? Dr. Irigoyen?
Yeah, of course.
Please, the mic is yours.
Okay, thank you. First, excellent presentation. Thanks to big winners earlier. I think that is very important to take time to carry out a good medical history and physical examination of our patient. Perform 100% venous Doppler, categorize our patient according to SEAP to make the best individualized therapeutic plan for each patient. Give them adequate follow-up after the treatment, and of course, encourage them to dance by teaching them the proper steps to activate the pump in their legs. Thank you.
Thank you so much. In reality, Dr. Irigoyen is mentioning a public venous awareness project we developed together, for which I'd like to deeply thank him again. Indeed, if you check on the BWIN Foundation page, you will see a video with evidence-based data about the cuff activation done by the vein dance we were used to do during the social gatherings of the meetings. And we will look forward for having that, of course, again in Buenos Aires and in Dubai, the first chance together. So now the mic remains in El Salvador, because we have another huge figure, Dr. Rodriguez, who is a dear friend and a pillar in the field. Luis.
Hello, good morning or good evening, everyone. I send you a big greeting from Central America. I am Dr. Francisco Rodriguez, President of the Fibrological and Endovascular Association of El Salvador. It's an honor to share the last webinar of 4x4 with you. You know, the COVID pandemic has left us a lot of grief and pain, but has also given us the opportunity to be more united like never before, especially with the West Island, with new medical and scientific communities in fibrological around the world, such as those represented in this webinar. You're talking about the thromboprophylaxis guidelines and the monitoring of the post-thrombotic or post-treatment patient. We know that we have a very high support and evidence that in the talk they show we have here today. The really point for our region or for our zone in Central America, Latin America, and West Iceland is the applicability of these guidelines, because depending on the many situations, depending on the medical resources, knowledge of the doctors, different levels when the practices are, custom, genetic of the patient, and something like that. But I'm sure that at the end of this webinar, many of us will have a more practical knowledge about the thromboprophylaxis and how we treat our patients. Thank you, Sergio, Oscar, Willie, Hugh, of course, Xavier for the support that they give us for education plan. And I will hope to see you again. I hope to be together in the new era post-COVID. Thank you very much, Sergio. Bye-bye.
Thank you so much to you, Dr. Rodriguez, and we look forward for enjoying other initiatives of yours in terms of education. You have done for many years now wonderful educational initiatives. Indeed, we look forward for being together again in person. Now, just a little bit change of a program, because we are going to have a huge grand finale with a grand lecture, so we'll save some time for that. And so we will just choose one question, Oscar, if you can, and the other ones will be answered in written form.
Here there is a good question from Maria Angelica Rojas. Does any practitioner evaluate the compliance of the clinical treatment The question is focused on the adherence to treatment. Do we control treatment compliance?
Well, we have a huge panel of experts. So Willie, would you like to take this one and give your perspective?
Yeah, well, I think that we all know that unless the patient uses it, compression stockings is really not going to work. So obviously there are various type of digital means that are in the pipeline that may help us with measuring whether or not patients wearing it. So I think that's quite important. That would be part of the overall treatment algorithm.
Considering the audience of general and internal medicine, would you like to stress out more the concept of interface pressure, please?
Well, yeah, interface pressure is a known phenomenon, but not really widely, I would say, used or recognized. The interface pressure, by definition, is the pressure from the compression material, whatever that compression product would be. It could be a compression stocking, could be a wrap, could be bandages on top of the skin. So that's really the definition of interface pressure. And typically we like it just like how we have our grades of different type of compressions, 20-30, 30-40, 40-50. Obviously, from the standpoint of the interface pressure, there are various tools that currently are commercially available. The one in particular will be the PicoPress system that came from Microlab in Italy. That is actually widely used using actual pneumatic physiology in terms of getting that pressure. So when you bandage somebody, it'd be good to have at least some way of knowing exactly are you reaching the right pressure. And the other thing that we use these tools is to teach the medical personnel, whether it be the nurse, the doctor, how to wrap the patient appropriately. So besides of measuring it, there is a strong education component to it as well. I'm not sure if that satisfies your question, sir.
Absolutely. Thank you so much. And now, as I was saying, we are going to have the grand finale with a grand lecture from somebody who needs no introduction, particularly in education. She has been an example for all of us, educating not only just a country that is already big, like Canada, but literally all the world. So the name is Pauline Reymond-Martin-Baud. So with Pauline, like for Professor Caprini, there is always an open path of talking for as much as you want. So we will let her talking for as much as you want. And then if we will have some time, we'll go back to the audience. If not, we will close. So I ask kindly to all the faculty to answer to the questions in the question and answer box of the audience in written form, so we can answer to everybody. And meanwhile, we will enjoy the big, great finale, thanks to Pauline Martin-Baud. Pauline, the mic is yours.
Thank you very much, Sergio. And it is a great honor for me today to discuss the varicose vein management. And hopefully I will encourage GPs and FPs to get training in order to approach this management and know how to do it in a sequential manner.
Maybe you want to use the other keyboard. Okay.
I have no conflict of interest. Varicose vein is a permanent dilation of a vein inducing a pathological situation. And it can be primary, secondary, or congenital. There are 7 vein categories on the superficial venous system of the lower extremity. You have the saphenous veins, the great and the small saphenous veins, the perforators, tributaries, and the intersaphenous veins, so-called Giacomini veins. These veins are varicose veins. You have also the reticular veins, the venulectasia, and the telangiectasia. These are the small veins. Varicose veins develop due to the dilation of the previously existing veins. And they are due to incompetent venous valves or parietal distension. The varicose veins are normally greater than 2 millimeters in diameter. Small veins are reticular veins, venulectasia, and telangiectasia. The reticular veins are the feeders to the telangiectasia, and they are around 1 to 2 millimeters, and they are normally green. Venulectasias are often located at the apex of the telangiectasia clusters, and they are blue. Telangiectasia develop due to the proliferation of new capillaries caused by venous hypertension, and they can be of different colors. Small veins are due to incompetent venous valves, and they can be responsible for significant reflux, especially when they're connected to the deep system, where we see in about 8% of cases, or to the saphenous veins, which is about 20% of cases, which is pretty significant. What is the success of treating varicose vein? Well, it depends on locating the points of reflux and treating incompetence from top to bottom and treating the deepest to the most superficial vein. Varicose veins need to be treated first and small veins afterwards. How do we know which reflux to treat? Well, there are multiple points of reflux sometimes, and one needs to connect veins to the most proximal point of reflux. Point of reflux are also often away from the visible vein. How to know which vein is which? Duplex ultrasound is a very useful tool, and it needs to be performed in the standing position for the superficial veins. And then it needs to be always done before treating or diagnosing a varicose vein. Now, this is a message for the GPs and FPs. Varicose veins may seem simple, but they are very complex. Let's figure that out. What's in the medical aspect of the lower leg? Well, you have the great saphenous vein, tributaries of the great saphenous veins, perforators, veins of pelvic origin, and revaus. The great saphenous vein runs anteriorly to the malleolus and at the knee posteriorly to the epicondyle, and it terminates at the saphenofemoral junction, and it terminates in the common femoral vein. Now, when this vein is pathologic, it has a reflux larger than 0.5 seconds. And when this vein is pathologic, it needs to be treated first before treating any other veins on the medial aspect of the leg. There are many treatments for the great saphenous vein: ultrasound-guided foam sclerotherapy, thermal ablation, laser or radio frequency, glue, MOCA, steam, surgery, or Chiba. Now, when the vein is large, maybe over 11 millimeter, it is, I think, important to look at alternative treatments than ultrasound-guided foam sclerotherapy. Now, tributaries are always treated after treating the incompetence of the great saphenous vein, and they are superficial, they are tortuous, and they are sclerosensitive. And a good treatment that received a grade 1C is the ultrasound-guided foam sclerotherapy. Phlebectomy or ASVAL is a very, very good treatment for the tributaries when the vein is larger than 10 or 11 millimeters. Now, the perforators connect the superficial to the deep system, and they can be of any size or they can be anywhere. Now, the exit perforators are refluxing perforators. There are the abnormal ones, and they are normally at the apex of the varicose vein. Now, the reentry perforators are competent, and they are distal to the varicose vein. A perforator with a reflux larger than 0.35 seconds is considered pathological. Now, ultrasound guided foam sclerotherapy is an excellent treatment for the small perforators. Now, the veins of pelvic origin, the important points in the medial aspect is the inguinal point, the clitoris point, the obturator point, and the perineal point. And they will give you some tortuous, very superficial varicose vein, which is very well treated with ultrasound-guided foam sclerotherapy, especially when you have to treat the lower extremity first. Now, if you have a congestive pelvic syndrome, I would recommend that the patient's been referred to an interventional radiologist. Revas, which are the recurrent varices after surgery, they are very thin-walled veins, very multiple veins, and they are very sclerosensitive. So ultrasound-guided foam sclerotherapy is normally a pretty good treatment for that. Now, always look for small arteries that are in the middle or in the vicinity of the revas. Now, what's on the posterior aspect of the lower extremities? Well, you have many veins. The small saphenous vein, the thigh extension of the small saphenous vein, the Giacomini vein, popliteal fossa perforator, tributaries, especially the posterior accessory saphenous vein, communicating veins, veins of the gluteal point, muscular vein perforators, sciatic vein, and also you find a lot of times some popliteal cysts that you need to recognize. Now, the small saphenous vein, it runs posteriorly to the malleolus, it runs in the calf, and the termination of the small saphenous vein can vary considerably. So it's very important that you use the duplex ultrasound to assess this vein. And I think the reason why there are very many recurrency after surgery of the small saphenous vein, it's because of that variability in the termination. Now, the ultrasound-guided foam sclerotherapy is also good for the small saphenous vein and its extension. And you have to be careful when you inject the small saphenous vein, since there is a small artery that is very, very close to the vein. One of them is the Dujarrier artery. And if you use the thermal ablation, which could be also an alternative treatment for the small saphenous vein, you need also to make sure that you locate the sural nerve, which is also very close to the vein. Now, the Giacomini vein is the vein that is connecting the small saphenous vein to the great saphenous vein, or the great to the small. And then it is well treated with ultrasound-guided foam sclerotherapy, since it is a very superficial vein, easy access, and it's very sclerosensitive. There's often a perforator at the in the mid Giacomini vein. Now, if the Giacomini vein is not treated and the two saphenous veins are not treated, there's always a higher risk of recurrency. Now, the perforator of the popliteal fossa. This is a vein that is often neglected and misdiagnosed and mistreated. So especially when treatment is done by surgery, it has been responsible for recurrency. This vein is above the popliteal crease, 2 or 3 centimeters above the popliteal crease, and it is also very thin. It's a direct perforator in the popliteal vein in 96% of cases, and it is a vein that responds very well to ultrasound-guided foam sclerotherapy, since it is easy access if you do it in injection distally to the perforator. And it is also responding very well to microfoam. Now, the gluteal veins and buttock veins are also veins in the posterior aspect of the leg, and they are also very superficial. So they can also be treated by ultrasound-guided foam sclerotherapy. Ultrasound-guided foam sclerotherapy is an excellent treatment for GPs and FPs, since it gets done in outpatient and doesn't need sophisticated material. Now, what is on the anterior and lateral aspect of the lower extremity? Well, always think of tributaries of any kind or veins of a pelvic origin. If the vein is smaller and green, think about reticular vein. Now, make sure that you always connect these veins to the right leaking point if you want a optimal outcome. When appropriate diagnosis is established and it is determined which vein is diseased and which vein needs to be treated first, sclerotherapy protocol can be used. Ultrasound-guided foam sclerotherapy is recommended for varicose veins. Macrofoam and diluted microfoam are recommended for reticular and venulectasia. Now, liquid sclerosant is pretty much what is used in low concentration and small volume for telangiectasia. What is microfoam? Foam sclerotherapy uses a sclerosant, a detergent, such as sodium tetrahydrosulfate or polydocanol, ethoxysclerol, and mixes it with air or carbon dioxide, with or without O2, in various ratios to create a microfoam. Microfoam is a foam made of bubbles of less than 100 microns. Most used ratio is 1 ml of detergent for 4 or 5 ml of gas. One of the good advantage of the microfoam is that it is echogenic and it can be monitored. What is a microfoam behavior? What does it do in the vein? Well, first it will displace the blood, and then it will create a vasospasm. There will be an inflammation that will be present in the venous wall, and there'll be a presence of sclerus. Sometimes the inflammation could be excessive, where you'll see erythema and the patient will complain of tenderness or pain. Later, after a few months, you will have a fibrosis. Now, when the patient has a fibrous cord and it can be palpated and it is painful, you can pretty much drain a coagulum, intraluminal coagulum, and that will help ease the pain, and this will help for healing of the sclerosis, and then it will prevent hyperpigmentation. How do you prepare microfoam? You can use the three-way stopcock, which is the Tessari method. It's a very popular method. You can use the DSS or female-female connector, or you can use the 2 ml vial. And if you're using a CO2, you can use a CO2 gas canister with a regulator. You can inject the microfoam by direct injection, butterfly injection, or catheter injection. Here is an injection by direct. This was an injection of the great saphenous vein. Now, what is a microfoam protocol? There has been some discussion and at the Cortina meeting from the VWIN Foundation, and there's no really consensus. There's a lot of controversies, and Sergio published a great paper in the Phlebology in 2019, and you can see the protocol or consensus of different countries. Now, what I think is common, at least in North America, is that injecting the great saphenous vein, you would tend to use 1% to 3%, and for other veins, 1% to 1.5%. For the volume, most experts recommend limiting the volume per session, and 10 ml and maximum 15 ml for a one session. Now, number of injections, that can vary, but I personally never do more than one injection per veins, and spacing my injections 8 to 10 centimeters apart. Now, when you do the great saphenous vein or small saphenous vein injection or guided foam sclerotherapy, make sure that you stay away from the junctions, 8 centimeter away from the junctions in order to avoid any intraarterial injection. Now, what are the endpoints? The endpoints is you're looking for a vasospasm after you do your injection, and you inject until there's no return of blood, and you make sure the foam is moving to the proximal vein, and then there's no side effects, no systemic side effects. Here's an injection. And you're starting now to see the vasospasm. Is there any complications to ultrasound-guided foam sclerotherapy? Well, the complications are rare, but all treated veins contain some extent of thrombus after treatment. In some cases, this causes a local venitis or superficial phlebitis, and the patient may complain of discomfort, pain, or discoloration. And again, you need to drain a trapped coagulum, and this is done normally 3 weeks after the injection. This is when you get your best result to drain it. Before that, the vein is still inflamed, and you'll get only red blood coming out of your puncture, but you need to wait so you get a very viscous and very dark blood so that you can extract from the cord that you'll feel. Now, what are the results? Well, there are several RCTs that have been published, and they show 80 to 90% of saphenous permanently occluded by ultrasound-guided foam sclerotherapy. And this is similar to the success rate claimed for other techniques, and especially thermal ablation. The ultrasound-guided foam sclerotherapy, however, has a higher recurrency rate after 5 and 10 years, but we have to keep in mind that it is a very cost-effective treatment. And for, I would say, GPs and FPs, I think that it's better patient comes several times for treatment, and the treatment is done in a very step-by-step, and it's a progression treatment. Now, let me discuss shortly the small vein injection. Now, reticular and telangiectasia that are on the lateral aspect of the leg are called the Albanese system. This system is very particular, especially on younger patients. And then this system, you need to treat the reticular vein first before addressing the telangiectasia. And the normal venous flow is downward to perforators. So the perforators at the knee level are there to drain the blood that is in the lateral aspect. And the perforators are most of the time normal. Now, small vein. Small vein is a tricky treatment. It looks simple, and then a lot of time the physician will ask a non-allied professional, I would say, to do the injection of small veins. Well, small veins are as difficult as large veins to treat. And it's very important to recognize and be able to read the small veins, so you see if they are clustered or not, see what's at the apex of the clusters, and then you always have to treat the reticular vein and venilectasia that are carrying the reflux to the small veins. And if you do it that way, you may not have to treat the telangiectasia because they will turn red after you eradicate the reflux. So you stay away from purple telangiectasia. Now, the telangiectasia can be treated by liquid or diluted microfoam or macrofoam. Macrofoam is a new technique and that I like to use on reticular veins. And this technique is made of spherical bubbles, and it is injected with a infusion set, a butterfly, 27 gauge, and the volume is always kept very, very small. Here's a video that shows you an injection demonstration. Here's the injection of a reticular vein where you need to aspirate blood before injecting. And if you look at my technique with the palm injection, you will see that I activate my fingers and then I use the palm to do the injection. I use a 26 gauge needle with an elongated special bevel because it's rigid and not as flexible as the 30 gauge needle. I introduce only the tip of the needle into the vein, and I pull back, and the palm will feel that negative pressure and it will inject for you. So it is a very mechanical way to inject spider veins. You kind of create a vacuum in the vein. Now, this is an injection with the butterfly of a reticular vein where a very small volume will be injected. Now, some of the complications that can occur with injection of small veins are histaminic reaction, which is pretty much normal, matting, hyperpigmentation, which is this figure shows, photo shows an excessive reaction of probably someone who injected haphazardly the telangiectasia without eradicating the underlying reflux. This is a hyperpigmentation that's pretty strong, and this hyperpigmentation may not go away by itself, and it may need a little undermining of the skin in order to fade. Cutaneous necrosis, in my opinion, it shouldn't happen. It happens if you inject, of course, outside the vein, but it happens also if you inject large volumes. And unfortunately, even doing small veins, you can always have AV fistula, or you can always inject some of the small arteries, and this, of course, will give a major necrosis. Other complications are very rare. Now, in conclusion, ultrasound-guided palm sclerotherapy is a safe and effective treatment. Taking consideration the diagnosis is accurate. If you want optimal outcomes, you need to make sure that you identify the right refluxing vein, and the treatment should be also performed with the adequate procedure, adequate sclerosing, and adequate dosage, and complications should be avoided. And I do encourage GPs and FPs to get appropriate training to do sclerotherapy and know when to say no, because it's not a simple treatment, and it may take, unfortunately, a few years before you can become very proficient doing this treatment. So know when to refer the patients to a colleague. I hope that your brain has been fired up enough, and thank you for your attention.
Thank you so much, Professor Raymond Martin-Beau. Now everybody knows why we are calling you among friends Queen Pauline. Please stop sharing your screen so we can introduce another huge figure from the field, and that is Professor Antignani, indeed a huge figure for having the honor indeed of having you with us. So it will be Pierluigi making the final honorary comment to you. Pauline, Pierluigi needs no introduction, President of the International Union of Angiology, dear friend. Pierluigi, unmute yourself.
Thank you, Sergio. Thank you for the invitation. And Pauline, very congratulations for your very complete presentation and the very fantastic panorama of the chronic venous disease and its treatment. I have just a question. Could you spend some few words about the particular syndrome, such as Klippel-Trenaunay or malformation, the diagnostic approach and the treatment of this syndrome?
Sure. Venous malformation is a complex, as you know, problem. Now, the syndrome of Klippel-Trenaunay, where you have an hemangioma, varicose veins, and elongated of the lower extremity, is a condition that you still can treat with foam sclerotherapy, depending on the size of the vein. And you can treat it also with macrofoam if the vein is not very large. Now, you have to be careful, of course. You make sure that you make your ultrasound mapping and make sure that you locate all the arteries that could be mixed with all the varicose veins. But it is a treatment that can be approached with ultrasound-guided foam sclerotherapy.
Thank you very much.
Thank you so much, Pierluigi and Pauline. I just take this chance to say that we have answered to all the questions in the question and answer box, apart the one of Professor Raymond Martinbot, who will answer during the last minutes. If you can, Pauline, have a look at the question and answer box. There are some questions for you there. And now we move forward with the huge finale of Professor Lorenzo Tessari. And indeed, if we are talking about sclerotherapy today and every single day in every single office around the world, I think it is because he showed us how to produce it in a proper way, in also a standardized and reproducible way if produced properly. Lorenzo, unmute yourself and the mic is yours.
Thank you. Dear all, I'm more than honored including this so important 4x4 project. The experiment of erasing out to general and internal medicine should I worked and paved the way for more and more teamwork. I would like to congratulate of the faculty with a special mention to the Central America and the West Indies colleague. We have learned to appreciate so much during this webinar, and that I'm sure we'll have many other opportunities of treatment with us. Looking forward for meeting you in person in Dubai next February. Ciao.
Thank you so much, Lorenzo. What I like to say is that we all know Professor Tessari as the huge figure in the field. I have the honor and pleasure of knowing him personally and considering him as a family member. I really encourage everybody to come and visit him. He's wonderful, of course, professional and equally wonderful person. And indeed, talking about wonderful people, I really like to deeply thank once again the ones who have made all this teamwork possible, starting from Professor Bottini, who initiated all the VWIN activities years ago together in Buenos Aires, for which we really look forward for being in Buenos Aires again next September. Oscar, the mic is yours.
Thank you, Sergio. Thank you all for excellent conference, good question and brilliant comments. I want to stress out the importance of the collaboration from South and Central America and with West Indies, as well as the importance of synergy with internal and general medicine, with phlebology expanding our specialty. Amazing, and we'll be waiting for you in Buenos Aires in September and in Dubai in February.
Thank you so much, Oscar, once again for the huge effort also done in delivering in Spanish all the 4x4 sessions from Central America. If we moved well and fast, it has always been because in these 4x4 projects, but not only in all the projects, we have a Ferrari engine, and it is the engine of Professor Chi. Indeed, that is always a wonderful example for all of us, both inside and outside the meeting room. And you see him already with a nice backdrop because the next educational trip will be directly from Asia. Willie?
Thank you, everybody. Good morning, good afternoon, good evening, and I hope you enjoy the 4x4. This is not the end, but the beginning. We'll see you in Dubai and all the other VWIN initiated activity, including the DIE project for Asia. Thank you.
Thank you so much, Willie, and always good reciprocate goods. And indeed, we'd like to deeply thank once again the other drivers of this 4x4 project, Professor Rial for the Central America group in Spanish, and Professor Zaza Salvatore Lazzarashvili, to whom I'd like to extend a special personal thank you also for all the activities developed with our Georgian Society related to the pelvic online project. And now the mic is for you, dear Salvatore.
Yeah, thank you very much, Sergio. Congratulations to everybody, all attendees, all faculty with the excellent project. And now I'm in the one of the diamond of the Georgian seaside Hotel Paragraph, which last 4 days become a phlebo-lymphological hub in West Georgia. It's a continuation of the Vein Week project, but now in person. And during these days, we had a lot of activities, some seminars, and also the humanitarian projects or consultations of the people and patients. And of course, this project is in cooperation and the organization of Servier. And together with me now, our friend and colleague, Professor Bokuchava, and also the chief of Servier, Georgia, Mrs. Maya Khetsuriani. And I hope we will have a lot of new projects with Within Foundation in the future, and hope that all activities and the awareness of awareness of venous and lymphatic disease will increase. Mamuka, also.
Good evening, everybody. Good evening, Sergio. Good evening, everybody. Congratulations for this very nice and very important project. It was very interesting to hear you and to hear those nice presentations. As Zaza told you, we have a return now to the one of the beautiful city from Georgia. We have the very important meeting with the GP doctors in the west part of Georgia, and it was a continuation of our project, Vein Week project, and the main topics of this project today was two topics. It was chronic venous disorders and VTE. Thank you again, and several words will from Maya will.
Thank you so much, guys from Georgia. And we now move forward because we have to finish in 5 minutes. So let me just move forward, deeply thanking all the ones who have been involved in this project that have not been seen. So I'd like to deeply thank Dr. Erika Menegatti as a PhD, always behind all our scientific activities and educational activities. I'd like to deeply thank Khaled for having us always protected by his technical expertise in all the things we are running. Our Holy Spirit, Gabi, who is there for all the interactions with Latin America. And of course, all the Latin America bridge with the Pura Vena, Pura Vida group of Flebo-Latam and LATAF bridging with Egypt. The bridge will go on also with the Central and West Indies with the V-Help project. It was wonderful to be together with many colleagues we have enjoyed online in these days, as it was in person in 2019 in Dominican Republic. We look forward for the next humanitarian mission in Guatemala. I really like this quote that is saying the greatest good you can do for another is not just to share your riches, but to reveal to him or her her or her own riches. So I like to deeply thank all the giants who, rather than going on stage, served co-working, helping others to go on stage online and soon in person. I'd like to deeply thank at the end all the ones who have been involved in this educational trip broadcasting from Central America and West Indies. I really like also this quote that comes from ancient Latin: spoken words fly away, written words remain. So you can enjoy all the recorded material in the Servier platform. And indeed, I'd like to deeply thank Servier for the unbiased support to an initiative that was indeed experimental, looking forward for synergy with general and internal medicine. A special mention to Alexa and Amankai for having always been present, starting from the 2019 experience with Alexa mainly in the HELP project, and Amankai this year from the 4x4 project. With this, we look forward for the next initiatives. Of course, the huge event of Buenos Aires when the world will gather together in September, indeed. So I remind you that the submission for the abstracts is open. As I remind you that you can report eventually encountered fake news in the venous and lymphatic field in whatever language in this webpage dedicated to the project related to the Winter Dubai. I deeply thank the more than 70 societies already involved in this group effort that will lead to the creation of the consensus document related to the topic and presented at the once-in-a-lifetime opportunity of the Health Week of the Universal Expo, the World Fair in Dubai. Of course, in Dubai, we look forward for starting again our social gatherings as it was in this nice picture from the Winter 2019. And even if we will have maybe to keep some social distancing in Dubai, no problem. We have a whole desert in front of the wonderful Dubai to keep some distancing for a good dessert in the desert. Until then, thank you so much, and see you from Asia with Willy, August 21st. And now, Khaled, please play the video. Ciao.
Bye. Thank you.
Hi. Thank you, Sergio. Thank you, Oscar and Willy.
Ciao. Ciao. Thank you.
Thank you. I don't.
In Bwin, we are used to say that it's not just where you're going, it's also whom you're traveling with. Deeply thank you then to all the ones who have been virtually traveling with us along the online educational Venus road to Dubai of the last months. And now it's finally time to start getting ready to gather together in person in Dubai. And the opportunity will be provided by the once-in-a-lifetime chance of becoming an active part during the Health Week of the historic Universal Expo during the 10th International Inter-University Meeting in Phlebology, Lymphology and Aesthetics. We'd like to deeply thank the more than 70 scientific societies and institutions already involved in the development of this project dedicated to venous and lymphatic fake news-free communication for our patients, but also to the improvement in the use of all the tools and devices we have available for the health professionals to improve indeed patients' care, and also on the importance of the certification and regulatory aspects of these tools. Everybody can be active already now by submitting eventually encountered venous and lymphatic fake news, so contributing to the creation of the document that will be presented in Dubai. In Dubai, everybody will have the opportunity to become even more active by presenting his or her abstracts in whatever language, thanks to the Your Work, Your Language initiative. We look forward then for being together in Dubai, together advancing in evidence-based venous and lymphatic practice, together redesigning the post-pandemic hybrid format of education. And since together has always been the key word in whatever Bwin activity as per the backdrop at my back, dedicated indeed to the 6th edition of the International Inter-University Meeting in Umbrella Island, I pass now the mic to Professor Bottini and Professor Chi, so that together we can invite you to be all together in Dubai.
Como anfitrión del 9º Congreso Interuniversitario Internacional de Avances en Flebología, Linfología y Estética, a realizarse en conjunto con las más importantes sociedades latinoamericanas del 25 al 27 de septiembre en Buenos Aires 2021, me honra también invitarlos a la 10ª edición de la que seguirá siendo un congreso histórico que durante la Semana de la Salud nos encontrará en la Mega Expo Universal, en donde todos los países del mundo dirán presentes en Dubái. Una vez más, contaremos con traducción simultánea al español, que al conjunto de la comunidad de habla hispana le permitirá mostrar su experiencia
e interactuar con organizaciones regionales e intercontinentales sin barreras idiomáticas. También será una oportunidad de reencontrarnos con los líderes mundiales, vinculándonos científica y socialmente. Espero con ansias, como todos ustedes, volver a vernos del 3 al 5 de febrero próximo, presencial o virtualmente, construyendo futuro en Dubái.
As the pandemic has been difficult for all of us, on a positive note, it has brought us closer together through digital platforms. At the next VWinter Dubai 2022, during Universal Expo Health Week, we hope to see you either in person or online to laugh, share, and learn. Simultaneous translation in multiple languages will be provided to enhance communication. See you in Dubai, where 2/3 of the world can fly in less than 8 hours. Thank you again, and we will see you in Dubai.
See you in Buenos Aires first, and then in Dubai, and a little bit before in Asia with Billy. Ciao, thank you all. Bye.